Hello, this is Dr. Sajid Iqbal from Pakistan. I have recently completed my doctoral study. My doctoral research was on culturally aligned smoking cessation interventions. And in that study, I did a scoping review. And I noticed that in South Asian region, we are all signatories to the Framework Convention on Tobacco Control of the World Health Organization. However, most of the articles of the FCTC are not followed in this region. And currently, I have proposed another study to see smoking hazards and tobacco harm reduction literacy among smokers in Pakistan. This is a multi-method approach. So today I will be briefly discussing about the introduction and the literature review and problem statement and solution, and then I will conclude this session. So there are overall 1.3 billion tobacco users in the world, and tobacco use claims about 8 million lives worldwide in a year. And unfortunately, 80% of the tobacco users reside in low and middle income countries, while combustible use of tobacco is the most harmful use. And unfortunately, in our region, most of the tobacco users have been found to be combustible smokers. If you see the prevalence of smoking in Pakistan, there are about 22 to 24 million active smokers in Pakistan, and almost half of the patients with cardiovascular or respiratory diseases are active smokers in this country. Hence, the current initiatives which have been taken are not working. Pakistan is, as I already told, signatory to Framework Convention on Tobacco Control. It has an ordinance on warning labels on the cigarette packets, which has been passed in 1979. And also in 2002, another ordinance was passed from the parliament, which says ban on smoking in enclosed spaces and protection of non-smokers. Under this ordinance, smoking is not allowed in any public spaces. But unfortunately, if you observe, you may easily see people smoking in restaurants and public transports. That means the current initiatives are not accepted or implemented by the society. There is also a national tobacco control cell. However, we can clearly see that only 24% of the smokers in Pakistan try to quit smoking in a year. 97% of these smokers fail to do so because there is no availability of proper facilitation. So, and hence, cultural acceptance is on peak for smoking. Therefore, some unique level of interventions is required in my country. It has also been observed that smokers and healthcare professionals are not aware of harm reduction strategies, especially the nicotine replacement options and other safer usages of nicotine. So, if we see, the first and foremost successful intervention will be the one which will lead to smoking cessation. However, if the addiction is high and smoker is not ready to quit, then we can switch him to a safer use of nicotine in order to make him safer from the health calamities of the combustible smoking in particular. So in my previous work, I worked on cultural alignment of the anti-smoking interventions, which showed success in almost 40% of the study population. And now I have read from the literature that in the countries such as USA, Canada, and UK, those who have introduced the safer usages of nicotine, they have exponentially reduced the smoking prevalence. So we can also adopt the same strategy to move towards the safer usages. Therefore, I have developed these objectives that first I will identify the nature and extent of tobacco harm reduction strategies and their awareness among smokers and healthcare professionals. And then I am going to identify the knowledge and skill level of the healthcare professionals about the tobacco harm reduction strategies in Pakistan. And based on these two stages, I will develop an interventional educational intervention through which I will capacitate healthcare professionals to give awareness and to switch the smokers towards the safer use of nicotine. So combustible smoking is on the peak in Pakistan, and reduction strategies are required, and safer use of nicotine are the most important one at this time. Thank you so much.